We are honored to have Mohammed Pate kick us off and talk about a world and global health community that is most certainly in transition. Mohammed has been a major contributor to global health policy for many years. As an internal medicine doctor and infectious disease doctor, he held the position of Minister of Health in his home country of Nigeria and is now the Global Director for Health and Population at the World Bank Group and Director of the Global Financing Facility for Women, Children, Adolescents, among many other positions. I've had the privilege of knowing Mohammed for over 20 years, and I am so excited that he is able to join us today to discuss his view of the new normal. Mohammed, over to you.
Thank you, EJ, for that introduction. And I appreciate your invitation and all the organizers for me to deliver this keynote remarks. I'm honored to join all of you participating at this 2021 PQMD Virtual Global Health Policy Forum. In the middle of the unfolding COVID-19 pandemic, the issues of access, equity, and inclusion are facing us squarely in the face. The pandemic has become like a mirror reflecting upon the state of the world, on all the goodness that we have, as well as all the areas that we need to improve. While we have learned a lot over the last 16 months, the pandemic is still very much with us, and there is a lot more we will come to learn and understand in the period ahead, as we are reminded by the tragedy that is currently unfolding in India, where thousands and hundreds of thousands of people are being affected daily. In the context of human history, we should have no surprises in the emergence and resurgence of pathogens to cause extensive epidemics and pandemics. Pandemics have impacted human society and civilization from time immemorial and will likely continue to do so. History of civilization is in fact shaped by catastrophic pandemics, many with significant impact on human welfare, culture, and on the very stability and security of nations and political orders. In the last 100 years alone, we have experienced several large-scale epidemics and pandemics with high cost to human lives, profound social disruption, and devastation of economies. Most recently, we witnessed the HIV Aids pandemic starting in the 80s until now. We have also seen several new pathogens emerge, including the coronaviruses and Ebola in recent years. Paradoxically, civilizational and technological progress increase the risk of infectious disease emergence and spread, given the growing and increasingly interconnected and urbanizing global population, the human incursion into natural ecosystems, and rapid globalized transport and commerce. So the frequency of outbreaks of emerging and re-emerging infectious diseases has been in the rise over the past few decades, but it's not inevitable that we always experience the severest impact from those infectious disease threats. There are things that we can do. I think we have reason to be hopeful. Following the Ebola outbreak that started in Guinea in December 2013 and through 2014, which affected several West African countries, there have been expert panels, including from WHO itself, which had concluded that the Ebola crisis then highlighted shortcomings of the existing international health regulations and the applications by countries and the global community of those regulations, which govern how we prepared and responded when threats like pandemics emerged. The WHO panel at that time concluded that member states of WHO had largely failed to implement the core capacities that were necessary, particularly under surveillance and data collection elements, which were required by the IHR. And nearly a quarter of WHO member states at that time instituted travel bans, for instance, and other additional measures that were not called for by the WHO, which significantly interfered with international travel, causing negative political, economic, and social consequences for the affected countries. And other expert panels corroborated those conclusions by the WHO panel at that time, including issues of broad lack of compliance, but also in terms of the necessity of reforms in global health governance to coordinate international response to epidemics and pandemics. Now, the recommendations from that experience led to the joint external evaluation processes and development of national action plans in many countries to address preparedness gaps. In all of those efforts, the private sector role in pandemic preparedness and response generally remained quite marginal. This is despite the obviously important functions that the private sector is uniquely positioned to play in emergency situations. The private sector itself suffers from the brunt of economic fallouts from large-scale infectious disease outbreaks, epidemics, and pandemics. Prior to COVID-19, it was estimated that pandemics could destroy up to 1% of the global GDP and cost roughly 570 billion. This was from the World Bank in 2017. Clearly, with what we have now seen in the context of COVID, we know that these were serious underestimates with the observed contraction of the global GDP in 2020. When COVID-19 emerged from China in early 2020, the high and upper middle income countries started bearing the onslaught of the pandemic, as we saw in parts of Europe and in the United States. Some of the lower income countries with weaker health systems managed to evade the sharpest edge of the pandemic, probably by some good luck, by demography, or some other reason yet to be identified. But we also witnessed some key gaps. For example, COVID-19 exacerbated inequalities within countries, with disproportionately severe impact on minorities, on the poor and marginalized populations, on women and girls, as well as those whose work required frontline contact. In the early phase of the pandemic, critical shortage of personal protective equipment, medical equipment, consumables, all produced and stocked and distributed by the private sector, became very pervasive in many countries. Almost in all countries, there were shortages in the early stages of the pandemic. There were thousands of firms, but there was no organized market enabled those supplies to reach the areas that needed it the most. And in some countries, hoarding became natural, even among some firms. Health systems, many of which were fragile in many countries due to underinvestments, inadequate quality human resources, and limited infrastructure, became under severe stress, as we are also seeing now in India. And before the pandemic itself, the WHO Global Monitoring Report on Universal Health Coverage had indicated to us in 2019 that the improvement in access to healthcare that we were witnessing as a global community was beginning to stall globally, and that access was not improving at pace to meet the SDG targets by 2030. Quality of healthcare was often variable, and financial protection was heading in the wrong direction, according to the Global Monitoring Report that was released in September 2019. So in other words, the recent increases, particularly regarding access to care prior to COVID-19, was coming at the expense of declining financial protection by people who were being pushed into poverty from costs of healthcare. Now, even those modest gains are being eroded with disruptions of essential care. This is really the world as it was, as we had experienced it. And with a new pathogen causing the pandemic, clearly vaccines, diagnostics, and therapeutics offer us an important pathway for containing the pandemic, regaining the losses we've experienced, and rebuilding a much better, stronger world that is possible ahead of us. Vaccines are now offering a viable path for ending the pandemic. But what we have achieved in terms of speed of vaccine development, we have not yet been able to achieve in commensurate scale and to ensure global access. Of more than the 1 billion doses of vaccines so far deployed globally, less than 2% have been delivered in the poorest parts of the world. We're seeing, with the ongoing surge in India and other countries, limited vaccine supplies, implying that a dual track world of those who have and those who don't have access to vaccines is almost inevitable. This situation is a major failing of global solidarity in facing a common enemy which continues to evolve and mutate. With the scale of the infection that we are seeing in the pandemic, delays in getting all parts of the world sufficiently vaccinated only increases the chances of more dangerous variants to emerge. Without vaccines for poor countries, nobody is safe, as rich countries can be affected by vaccine resistance variants being re-imported. Therefore, inequality is in essence bad for everyone. It is bad for the public sector, it's bad for the private sector, and it's bad for the world. So let me now share with you my reflection on one key lesson that we have learned in terms of what I see to have worked quite well. In a complex issue such as pandemic preparedness and response, there is no single sector, institution, or country or industry that can solve it all. Networked governance has become necessary. And network governance is characterized by the collaboration between multiple parties working within their own systems and capabilities towards a joint objective. It can work without even a formal framework, which takes time and transaction costs to establish. Rather, using informal networks to exchange information, signal action, and build trust to achieve a common purpose. An excellent example of network governance manifested in the Access to COVID-19 Tools Accelerator Alliance, which just hit its first one-year milestone. The Act A, as we call it, at its core comprises WHO, UNICEF, Gavi, CEPI, Global Fund, the World Bank, Global Financing Facility, UNITAID, as well as the pharmaceutical industry represented by FPMEA and DCVM. The Act A pillar on diagnostics, which is led by FIND and the Global Fund, was able to support the independent assessment of over 60 antigen rapid diagnostic tests and benchmark them to inform government procurement of the COVID-19 tests. Over 65 million COVID-19 tests were procured for lower and middle-income countries and lower middle-income countries. More than 23,000 health workers in almost 200 countries have had access to training to effectively implement those tests. The diagnostics pillar of the Act A is positioned to procure now 900 million tests by the end of 2021. The second pillar of Act A, the pillar on therapeutics, is led by Wellcome Trust and UNITAID, and it contributed by tracking more than 300 actionable trials across products, including monoclonal antibodies, novel antivirals, and repurposed therapeutics. It supported research that identified dexamethasone as a life-saving therapy that it is for COVID-19, provided guidance on its use, procured via advanced purchase 2.9 million doses of dexamethasone, which is the only WHO-approved treatment for COVID-19. The therapeutics pillar also formed the Oxygen Emergency Task Force to confront the surges in demand and to cut preventable deaths. It identified millions of dollars in immediate funding needs for medical oxygen in 20 lower and lower middle-income countries. It supported several clinical trials investigating 21 therapies in 47 countries, with more than 85,000 patients enrolled. It analyzed various clinical trials to identify promising treatments that could be scaled up and funded multiple large-scale additional studies. The Act A pillar on vaccines, which is led by Gavi, CEPI, and WHO, worked with UNICEF, the World Bank, and others, and invested in R&D portfolio of 12 vaccine candidates. In an unprecedented manner, we've seen many of those vaccines being available to poorer countries in all parts of the world, including now a vaccine manufacturing task force to optimize and prioritize the number of doses manufactured in the short term for COVAX. It has delivered more than it has delivered vaccines. It aims to deliver 2 billion doses of vaccines in 2021, if the supply situation that we're seeing, which is fragile, endures. And at least 1.3 billion of those doses will be for AMC countries. That is not for certain, but I think that's the expectation that the Act A COVAX pillar intends to do. While the Health System Connector is helping countries strengthen their health systems to be able to deliver the tools, whether they are vaccines, diagnosis, and therapeutics. So in terms of the Act A as a network governance arrangement, we've seen that it has brought together disparate institutions where a complex issue has been tackled and is being tackled. Imperfect as it may be, the network governance arrangement through the Act A has achieved some important steps that I think have to be acknowledged. We need to build on these lessons so that we can do better next time on speed, at scale, and with global access in mind to ensure that no one is left behind. Of course, there are several other informal networks out there which would need to be harnessed. The antithesis to network governance is tribalism. Unfortunately, also a trend that can be fueled by complexity and societal challenges. Tribalism is characterized by using language that excludes others, that exaggerates differences, that escalates disagreements, and exploits each other's vulnerabilities. In conclusion, COVID-19 pandemic has exposed challenges in the governance of global health to ensure both pandemic preparedness and quick response that is efficient, effective, and equitable. And weak global consensus and critical gaps in areas such as development and financing of new technologies and supply chains for essential equipment and commodities has become more apparent. When the chips were down, countries and regions looked after their own interests, including holding limited supplies, and that the global solidarity that we all state in terms of aspiration became very frayed. Network governance, for example, through the Act A, imperfect as it may be, still offers an alternative architecture for governance of global health, so that there is truly inclusive, multi-stakeholder effort to address the need for speed, scale, and global access for the pandemic response, but also for other complex needs of our world today. So thank you once again for the invitation. I look forward to the discussion. Thank you. Over to you, EJ.
Hi, thank you. Can you hear me? Everybody is a little frozen. Okay, thank you. Thank you, Mohammed, very much. That was really, really interesting. So we do have some time for questions and comments. So if you'd like to chat them in the chat box, I can grab them. If you have any, do you have any questions for Mohammed? Sorry about this. My internet is a bit weird today. Can you hear me? Can you hear me? Anybody?
We can hear you, EJ.
Okay. I cannot read the chat. It's blank for me. So are there questions? I actually have a question if there are no questions.
Why don't you start with your question and we'll monitor the chat box. Sound good?
Okay, thank you. Yeah, sure. I don't know. Yeah, it's completely blank for me. Yeah, my question, I guess, Mohammed, so incredible emergence of these networks, and I mean, COVAX obviously is the big elephant in the room, and there are many others, and you named all these partners that have come together, which have come together before in other epidemics and pandemics, and they are certainly disparate institutions, and happily include also the private sector. What? I mean, when you said they're inclusive, I didn't actually hear too much about the national governments that are potentially engaged, or the client countries. Where is their voice? How do they get heard, and what kinds of outreach is being done to engage them? I'm obviously the World Bank is a major pathway to those voices, but how would you how are they involved? How are the client countries involved, and the national governments? And by the way, now I see the chat. Oh, okay. Somebody else better monitor it because it keeps freezing and going off.
Yeah. No, thank you. So if you take the COVAX facility, for instance, 191 countries had repeated engagement through the WHO mechanism, but also Gavi by itself, in terms of their interests, and that's how they participated in the COVAX pillar, both the self-financing countries as well as the 91 or 92 AMC countries, who are the low-income and lower middle-income countries. In addition, the Facilitation Council of the Act A is co-chaired by Norway and South Africa. Through the various pillars, there have been repeated engagements with country leaders. For instance, we co-lead, along with the Global Fund and WHO, the Health Systems Connector pillar. We've had countless engagements with ministers, with senior officials in country governments to get their perspectives as well. Because the way that this will work in the long run will be a combination of sort of top-down approach with bottom-up approach that respects country leadership and country ownership. Imperfect as it may be, I think it's a great start. We can build on it and configure it such that, let's say, there is proportional representation over time. But in a complex situation like we have in a pandemic, we have to think about harnessing all those networks with inclusion of all voices at the center of our approach. And Act A, in a way, has tried to do that. And I believe that it's continuing to refine that, including bringing, let's say, the African Union more into it, even though the co-chair of the Facilitation Council was the president of the African Union, for instance.
Thank you.
Thank you, Mohammed. I see some questions in the chat, and if your audience are okay with it, I'm going to call on you to ask your question directly. So Michael Anderson is first. Can you unmute and ask your question?
I can. Thank you very much. I'm a bit naughty of me to ask this question, Mohammed, but I wonder if you could just tell us how the World Bank responded to COVID by changing systems or innovating or moving faster. What were the main changes that the bank introduced?
Yeah, no, thank you. I think the bank did what it has never done before in any pandemic. Within a couple of weeks after the outbreak escalated in China, we convened the first task force, what we call Vaccine Development and Financing Task Force, with CEPI, with Gavi, with WHO, with the Global Fund, and many other actors to discuss development and financing of vaccines and new technologies. That was in February, and we were able to activate that and publish it actually in March in the Lancet, calling for global fair allocation mechanism to be established. By March, our board approved a fast-track facility that included $6 billion for countries and $8 billion for the private sector. $4 billion of the $6 billion for countries was new money and $2 billion was reallocation. That was to enable countries to respond immediately. And by April 2nd, we had 25 country projects approved. And within 100 days, we have reached more than 100 countries with resources at hand to respond to the emergency situation that was unfolding. And many of those projects became effective within a month. That is unprecedented if you know how long it took previously for the bank projects to come into being. By October, when vaccines were becoming a reality, our board approved $12 billion for additional financing to support vaccines and the delivery of those vaccines. This required a number of changes in how we managed network within the institution. So we created an emergency operations center that brought together various parts of the bank with the health practice to coordinate and support teams to be able to interface with our clients. That mechanism, in a way, has enabled the bank to deliver something that was really profound and has never really been done in the context of what we've done before in terms of health response.
What a fantastic time to be involved at the bank. That's amazing. One last question I think we have time for. Veronica, can you unmute and ask your question? It's very pertinent to our organization.
Hi, Dr. Mohammed. Thank you so much for your comments. I wanted to just get your perspective based on what you know from PQMD. What do you think a network organization like this can add to the conversation? You know, how can we accelerate? You know, given over 40 organizations that are obviously cross-sectoral, you know, both private and NGO, how could we help accelerate stakeholder engagement?
Yeah. I think there are several, let's say, informal networks that exist, including PQMD. I think harnessing them requires thinking through elements that will make them both efficient as well as effective. Having a common goal in terms of clarity of what it is that you're trying to accomplish, and for the group, rather than each entity pursuing its own objective within the context of the network. Having a lead broker, an organization that basically helps either as an active participant or acting as the hub for the network would help. And that members of the network themselves feel really have a sense of shared decision making, and that they feel they're not losing their autonomy, but they're contributing to a bigger goal to be accomplished. Engendering trust between entities that are operating, ensuring sort of density of the network is maintained, balance between sort of informal engagements as well as the formal engagements, so that there are multiple channels through which institutions within that cohesive network interact. That's, for instance, what I see in the context of Act A, where we are participating both in terms of the formal structure that we have established, but also outside that as very institutions. then the breadth and depth of the engagement across institutions, not just one person, but several folks to participate. Understanding the mutual dependency across different actors of the network. Those would be necessary for the network to function effectively and efficiently. Of course, there will be tension in terms of whether that is, to what extent you go for inclusiveness and trade-off efficiency, or who controls versus the autonomy that institutions within the network actually have. So within that, if you look at vaccines that are now, the issue of vaccine donations, for instance, is become very topical through COVAX, but there may be other things that I think PQMD can organize itself and try to solve as a collective, as a network, focusing, let's say, on the poorest countries. I've just mentioned, for instance, that less than 2% of the vaccine doses that have been deployed are in the poorest parts of the world. So there are avenues that the network can deploy itself. It doesn't have to be fixed and perpetual, but at least it can convene all those actors to solve an important problem at a time.
Thank you.
I think Mark had a question regarding, I don't know whether...
we have 2 minutes.
Yeah, regarding bunching of vaccines.
Yeah, you're welcome to answer. Mark had to go into the green room. He's on the next panel as well, so he's
okay.
No longer in the room. But Mohammed, thank you so much for your insight and your advice to us as a group, and for spending your time here today with us. We're really very lucky to have shared this the morning with you. Any additional questions, including this one, we can go ahead and take to our community of practice, where we can continue the discussion.